Okay, so thank you everyone for coming down to the final panel session of the day. Really pleased to be here at Power to Disrupt to talk about current and future needs of diagnostics in the NHS. And thrilled to welcome our panel of experts for this afternoon. And I think it's always best for the experts to introduce themselves rather than for me to try to describe who they are and what they do. You'll notice, those of you that are very observant, that the picture and number doesn't match the number here. So Nuala passes on her apologies. She's not well today, so she isn't able to join us. But of course, we hope she feels better soon. And if you do have any questions specifically for Nuala, who is from the Health Innovation Network in Kent, Surrey and Sussex, then I can pass those on to her. So for today, we're going to be having conversations, and we want that to be including everyone, so questions as we go along. We have a roving mic, which we'll try and get round so we can hear your voice. And I think really let's start by asking each of our panel members to say who you are, where you're from, and tell us a little bit about what you're looking forward to discussing as part of the panel this afternoon. Start with you, Helen.
I'm Helen Dent. I'm Chief Executive of BIVDA, which is the British In Vitro Diagnostics Association. The vast majority of companies upstairs have belonged to us as our membership. My background is procurement and market access, and that's very much what I'll be bringing to this conversation. I'm really looking forward to just talking about adoption and uptake and some of the examples, because it's something that I really believe in, and I will talk about diagnostics for hours, if allowed.
Thank you, Helen. Good afternoon, everyone. I'm David Thorne. On there it says I'm from a company called Health Policy Explained. I'll do that part-time. It's a market access agency. The main thing I'm going to talk about today, I'm Director of Transformation in the Primary Care Network in the far north of England, in Northumberland, up on the Scottish border. And I work with Neil, who's sitting in front there, who's put his hand in there, who's a GP, who's one of our GPs there. And what I'm really looking forward to today is I have a one-line job description in that respect, okay? Which is, how do you make it happen? Make it happen. And I've really enjoyed going around the exhibition stand today. Neil has as well. And we've really enjoyed seeing the technologies up there. And that's what we're going away with tonight. How do we make it happen? And I'm really interested in your ideas.
Thank you. Good afternoon, everyone. I'm Sylvia Stevenson. I'm the Director of Absolute Diversity. A broad background, but really managing and running my own consultancy today. Most of my clients are the NHS, and I live and breathe all things inclusion. I look at the systemic issues. I'm interested in what is in the system, what's structural, and I'm determined to roll my sleeves up and get some results. I am really interested in looking at understanding and exploring what are some of those systemic issues. What do we understand about them? And more importantly, what are we doing about them? So I'm looking forward to a very rich and positively disruptive conversation.
Thank you, and thank you to all the panel members. So my role for the panel this afternoon is to keep everyone talking and keep the conversation moving. So for those of you that don't know me, I'm Lucy Lehane. I'm an independent medical diagnostics consultant, having worked in diagnostics through all of my career, starting at the NHS as a clinical scientist. So having seen both the NHS story and then moving that into the commercial world. And I'm pleased to work with BIVDA as part of their innovation programme and leading their Springboard group. So what I'd like us to do this afternoon is really dive into the topic of the past, the present and the future for diagnostics within our NHS, and thinking about discussing all of our experiences and what we can learn from those and apply those to the future. And we also welcome your questions, so please raise your hands when it's an appropriate time. The way that I'd like to structure it is that we talk about, first of all, the past, and we'll have some debate and discussion around that, and then open to questions. Then we'll talk about the present, and again take some questions, and then the future, which I think is the most exciting part for all of us. So I'll try to keep the flow going and keep us under control. And I think to start with, the most common quote we all hear, which is from a 2017 paper from Clinical Biochem, is that 70% of clinical decisions are made with a point of care or laboratory diagnostic test. And I think we all probably still hear that used and hear that quote. And I'm interested, starting with you, Helen, to think about how that quote holds today in 2024. And when we think about the use of diagnostic testing, do we think that 70% still holds?
Thank you, Lucy. So it probably sounds quite brutal, but I think it's probably the same, because I don't really see any significant uptake of extra diagnostics over certainly how long I've been working in diagnostics. So I don't think there's been significant change. I do think as well that some of the testing and some of the diagnosis is direct with consumers and direct with the public, and I don't see that any of that is taken up into those clinical decisions either.
David?
Yeah, it certainly holds true for me. I'm looking around the room furiously. I can't see anyone older than me. And so you do need to laugh out loud. So, I was a nurse originally. I've worked in hospitals. I've worked in primary care, community care. Really interesting what Helen's saying there about something that I've occasionally called meta-primary. Now I think that's an area. So firstly, diagnostics is absolutely pivotal. The history of why I'm here today, I met Tony, Katie, met BIVDA probably about 15 years ago, because I started to come to these events as a delegate. I worked in a different role. I don't have your expertise in terms of pathology and point of care, but I came to try and educate myself because I kept seeing that diagnostics was a central part of the pathway. But here we are 15 years later, and this is coming from a friendly place, I promise you, okay, is when I'm around, say, ICB transformation meetings, and you start counting off the disciplines, I'm thinking, where are the likes of you? Where's the scientists? Where's the people who are experts on diagnostics? Where are you? Okay? So I'm saying this from a friendly point of view, that things I used to seek 15 years ago, things have changed, but there should be more opportunity for you. And yet you're less present, and I don't understand that, okay? Similarly, the final thing I'm saying, one of the things that's changed, we're getting a little bit into the present, I suppose, is the sheer number of roles. I mentioned that I was a nurse there. Well, when I was a nurse, no nurses prescribed. Who prescribes now? What do healthcare assistants do now that we didn't do 40 years ago? Okay? So the world is changing, but where I see you guys stereotypically is locked in the labs. So let's have an energetic discussion today. Let's challenge, and I say coming from a friendly thing. Sylvia mentioned it first. Tony's got a great name for this event, the power to disrupt. Be disruptors. Yeah, otherwise we're going to continue to be in that historic past position, and we don't need to be at all.
Thank you so much. And I'm just going to build on that, actually, when we look at the past. So I'm coming at it from a totally non-clinical background, right? So I'm thinking more about the patients. And when I think about diagnostics, yes, I do believe that there has been some change in the last few years. But if we sort of went back to COVID, for example, we know that it accelerated innovation for diagnostic testing. There was more adoption of diagnostic tools, etc. There was greater distribution of tests, PCR, the antigen tests, all those great things. Innovation was great. But when I look back at the testing and the impact that it had for certain demographics in the community, it's actually quite heart-rendering. And they still exist today. So, for example, we know that well-documented use case of the oximeter, and the fact that it was a crucial requirement for testing the symptoms in patients. But we know that people from racial, black, minority, ethnic groups, people with darker skin, the testing accuracy was not correct for them, which led to people not being diagnosed correctly, people not getting the right care. And the numbers are there. People from black, minority, ethnic groups suffered some great mortalities. This is the reality of when we talk about testing, what's happening. I think there were a lot of technology barriers when you come to vulnerable populations. We saw great adaptation of, digital apps and digital health tools. But what about the older people who may not have been technically savvy and who may not have been able to have access to smartphones and to, the internet? So I think that whilst I've seen some movement in the sort of digital diagnostics, the systemic inequalities still exist. And the rhetorical question, not that I'm raising one here, is if we were to have another pandemic, God forbid, would we still be having the same conversations? Would we still be going over the same issues? And would the same people still be impacted? So again, what are we doing to eradicate and lessen the risks for marginalised and underrepresented populations?
Yeah, and I think that begins with the clinical studies that we're doing before we launch the products. And with the pulse oximetry, for example, it's been recognised the problems, but actually the FDA have said that you have to include up to 15 people in your pulse oximetry study. That's insufficient. That's not enough. Yeah. So it's a small movement, but not enough to make the difference. So, Sylvia, you brought up COVID. I think that's a great move into the discussions around we can't ignore the fact where we talk about the past and we talk about diagnostics, the huge impact that COVID has. And Helen, perhaps you can give us some positive impacts that we saw from the pandemic that really helped the diagnostics industry.
I actually can. So what was really good in the pandemic was the way that industry and the whole system was able to work together and to actually deliver a solution that gave test results in the time that was needed and timely enough to impact clinical decisions. And I think there are lots of challenges. The NHS is as broad and the tests available are as broad as the NHS. So granted, there was one problem to try and address and one problem to fix. But what came out of that, which is slightly less positive, is that it's starting to kind of revert back to type. But what did come out of that is the ability and the understanding that people can work together and can actually address problems together. And I would like to say that does still exist, but we are very much at risk in letting it go backwards.
So should we pause there and ask if anyone has, we're talking about the past and diagnostics in the past. Does anyone have any questions they'd like to raise with the panel before we move on to talking about the current day and the present day? We need someone to be brave to start it off and then everyone will be twice. Anyone's other questions? We have a roving mic if you don't have a loud voice.
What did the panel think that in the past that we did well that they want to see us actually continue? Because there's being a disruptor, as David said, there's changing things and changing that. But do we need to change absolutely everything, or is there some things actually we should hang on to and keep going or keep doing in that direction?
I would like to see you, it's sort of related to what David just said as well, is that we saw you as a resource, that you were consulted and you were absolutely part of all of the decision making and the processes and the groups that were in existence, and you were very visible. And currently I would argue that as a profession, you're not far enough into the pathway the other way to start to influence the decisions of what to be used and who certainly my members are trying to talk to. They are much more in the clinical pathway. You're just too far towards the end, in my opinion. So I would like to see more of how it was then.
Dent?
I'm going to do what the politicians do. I'm going to take one question and give a slightly different answer because there's something I want to say, okay? But Katie, I'd be too scared of Katie to ignore a question completely. So I'm going to build on it. It's coming from a friendly place, yeah? So as Helen was saying, you guys were much more central because people needed your expertise. And it's a bit of listening to my colleague Neil today. It's the first time he's been to an event like this. And it's probably the only GP who's in the room, okay? Is do not underestimate how much we want you guys to continue to be experts, okay? So if a patient pathway changes and we start to do something outside hospital that in the past was inside hospital, that doesn't diminish your authority at all. Because what Neil and my other GP colleagues would like is for you to come out as the experts and help to design those new services. Yeah? And I know most people here will spend the majority of the time in hospital, but the majority of healthcare takes place way outside that, and the opportunities are way outside that. But you could guide it and you could lead it. So Neil's going away today, I know, with half a dozen things he's seen upstairs that we would like to try out as prototypes. And if there's anybody here from our local hospitals, and you know who we are if you just come up and grab us, we want you to guide us and advise us. We want you to be the experts, to be the chief, what would you be called? The chief diagnostic officer for our area, okay? So it's a slightly different answer, but it's a message I want to send to encourage you that there's a great big wide world out there. And it does kind of link back to COVID. And the final thing I'll say in COVID, the first 10 years I spent in the NHS in England, we had an integrated NHS. And then we started to throw snails into each other's gardens. Yeah? And hospitals became competitors with each other. And some of the innate tribalism we had in the NHS came in. And as Sylvia in particular has said, it's sad since the end of the pandemic, some of that's drifted back in. And we're supposed to have an integrated NHS. So it links to the stuff I was saying before. I would really like to see you guys, as a community practice, as a profession, become holistic diagnostic officers and specialists and experts. So that you advise people like Neil how we should use the new machinery, the new opportunities, the new technology, the new pathways. How does that extend outside hospital? Because you're still the experts on it. You're the subject matter experts. Let's see more of it in a broader sense. Sorry, so it's a political answer. Sorry, go on, Sylvia.
Well, I'm not from a clinical perspective, so I don't know the history, but it was interesting when I was in the previous session at the beginning, this lady that just asked the question, she was talking about patients. And I think it's keeping patients at the heart of everything. It's so important that we remember who we are creating, inventing, designing for. Too often we have solutions and pathways that are not diverse, that are not inclusive. We shouldn't be satisfied to just go with the norms. And just based on what David is saying, if you are the experts, then make your voices heard. And the question I would ask you is, why aren't they finding it in you, stopping you from saying, actually, this is what we need? We need that diversity of thought around the table. It is essential that this diversity in the room is amazing. Wouldn't it be great if it was this type of diversity that went into creating pathways, that went into designing solutions and technology for patients? Because at the moment, I see it all the time. It's the same old, and we're having the same old discussion. So I don't know if that answers your question. I'm either bad influence, either bad influence in sorts of.
I'd like to stay with you, Sylvia, if we can, and bring us into the present day.
Yeah.
And if we think about diagnostics in terms of access to testing for patients, can you give us some examples of where the access is a challenge and how we can make some improvements in terms of the EDI aspect?
Yeah, so from an EDI perspective, I promise you I don't always look for the bad things. I always look for the good things as well. I know what good looks like. But if you think about the historical factors that impact, on the 17th of May, I held a community listening group with the intention of talking about gender bias in AI. I thought, wouldn't it be great to talk to all these different women from different ethnic and racial cultures just to really get their views on it? And we couldn't get past this lack of health education and this lack of mistrust in healthcare. In actual fact, I was quite surprised, very, very surprised. So I think the barriers is really what you hear is the rhetoric: we can't get access to test and we don't even know what to ask for. I think the bigger challenge is the clinicians that are actually dealing with patients and explaining the results. They need to be culturally competent. We have to be culturally competent. It's not a one-size-fits-all. And so what we find is that it's more than just communicating. I think it's connecting with patients to help patients to understand what is that result. And that's against the rhetoric of, are these really my results? Is it really real? Is this system working for me? So when you look at the Black ethnic minority community, there are a number of issues, myths that are happening, playing out in the community. And yet these are the communities with the highest level of chronic illnesses, as in diabetes, and as in hyperventilation. I know that there was a report, I've got it in my notes because I like menopause brain otherwise. I think it was the NHS Race and Health Observatory released a report in 2022. And the biggest factors was the waiting times. Clinically proven, data proves that people from Black ethnic minority, underrepresented, marginalised communities wait longer for things like x-rays, screening, cancer. So I've given you a number of things, but I think it's about the lack of understanding of patients and seeing them as an homogenous group as opposed to looking at that diversity and that profiling of patients. We've got a lot of work to do in that space.
Yeah. I think if Nuala were here, one of the things that Nuala was going to talk to us about today is the new toolkit, the innovator guide that the Health Innovation Networks have launched on health equity. And we'll share that link with you because it's a really good report, really good document that summarises some of the things that Sylvia's mentioned. Maybe, David, you could talk to us a little bit about access in communities and how where you live is a huge, sometimes blocker to your access to diagnostics.
Yeah, absolutely. And I've really fantastic listening to what Sylvia said. It's not meant to be a competition with her in any way, but Neil and I work in an area that's probably the most homogenous demographically, okay? So our issues are slightly different. So some of the patients of Neil's will live 70 miles from a hospital. The mean population density in England is a fact. It's 434 people per square kilometre, okay? Our population density is 9 people per square kilometre. We had the last community in England that wasn't connected to mainstream electricity. Okay, little village, and it's now got electricity. It's quite common that we don't have gas. Okay, so it's a very different kind of environment. I live in one of the bigger villages. There's only one mobile network works on it. So it's interesting to go again around the exhibition stand and see people saying the smartphone, that. Simply said, there's issues around elderly. It doesn't matter how old you are. You could be 17. In my village, probably 6 weeks a year will be off because of snow, subsidence. We were cut off the other day with a fire. There's all kinds of issues that happen. Raoul Moat with a gun. That was one of the reasons we were cut off as well, which is slightly less amusing. 2 examples I want to give to you is invitations to, and it emphasises the point I was just making, but it also should chime with the people who were in the exhibition stands upstairs. So we run a program called Seafit. Now this is for the guys who go out on trawlers, deep sea fishing from some of our coastal communities. They don't have time to go and get vaccine in, so have conventional healthcare. Yeah, when the weather's right and they want to earn money, they're out on the boats and they're fishing. One of the things that we discovered is if we had a gazebo on the fish quay, so they literally come off, land a fish, and we do finger pricking, looking in their eyes. We have physios there, GPs, and we're doing examinations for prostate cancer on the fish quay in the northeast of England in the winter. Now, one of the things we discovered with that, it was really interesting, this from Sylvia, is about 30 guys who are from the Philippines who were working on the boats that nobody knew anything about and weren't registered with GPs. So it's really interesting what you find, you go and look for it. The final thing, and if anybody's got experience, if you want to grab me and Neil about this afterwards, Our big flagship program at the moment is something called FarmFit. Now, if I say farmers markets to you, you're probably thinking of people in very nice barber jackets paying a lot of money for overpriced cheese out the back of some thing. Our farmers markets is people selling animals, agricultural markets, and it's far less glamorous. So we do the same thing now for FarmFit. So one of the things that we were looking for really today, when we're looking at the various things around the stands, is what would work with FarmFit. What would work? Blood, urine, feces, sputum, what we testing, how would things work for that kind of community? So the final thing, I don't know if anybody noticed though, there was a stand there today that many people wouldn't have been expecting. And it goes back to the challenge I'm throwing to you. Do you see the stand for something called ZEO? Yeah? And you might be thinking, what are they doing at point of care testing? But for me and Neil, that's point of care testing. And that's something that we think of the FarmFit community, or those guys going out on the boats. And when you think of FarmFit, it's not just men. The people who work on the boats are nearly all men. But in the farming communities, it's both genders and all kinds of age groups. But something like that, wearable devices, absolutely fantastic. Okay, but that's the kind of difference. Connectivity on IT, remoteness, fiscal remoteness, people in occupational jobs that mean it's very hard to keep conventional appointments. And can you do things once and do them very quickly and do them very conveniently? Okay, so we're really interested if anybody's got any ideas around FarmFit. Which way are we going?
So if we go to Helen next and build on that, David, from what you said, and really thinking about barriers and challenges that we see that are hindering the uptake of diagnostics. And if we could focus on community hubs, and there was a lot of talk about respiratory hubs during the pandemic and in the days and months following, but where are we with community testing in the light of Lord Darcy's report last week?
We've been doing a lot of work at the moment. It's been really interesting as well, in that I think we all together need to understand collaboration a little better. And where I'm coming from that is there is a marked difference between what the NHS says it needs compared to what it actually needs. And then the same marked difference again to what industry understands is the requirement compared to what the NHS actually needs. So terminology is important when we're talking about something like this, because there's a difference between the clinical need and then the clinical utility. And then when we've got the clinical utilities, what do you want to use it for? That's where we then start to get into some of the conversations that we really can help with in terms of equity and access as well. So place-based care is really, really important. And part of that place-based care has a huge number of processes behind it. And then the commissioning of that care, for example, has to come from the local area. The local area is then going to take into consideration all of the things you said about the demographic. As a manufacturer or a provider, it's really difficult to provide the necessary evidence and requirements for all of those different areas that you're all asking for at the same time. So there has to be a better way of getting that raw information out of industry, all the way from the innovators who have got something specific for their local area because something might have happened for them, all the way up to the big manufacturers who are trying to comply with massive IVD sector legislation that they've got to provide certain clinical data. If we could work out the difference between the clinical data, which is how does it work, and then all of the different ways it can be used, and then all of the evidence that will be accepted across the whole of the NHS, and then the differences can be regional, can be local, and can be place-based, then I think it'll be a lot easier to implement those really good innovations that are currently stuck at, here is my clinical data, what on earth do you want me to provide evidence for? Because that's where we're stuck for at the moment. And that is my segue into ARI hubs. So, with the ARI hubs, it's taken 3 years, 3 failed pilots to get to the fact that they didn't want to know what the clinical effectiveness was for it, but they wanted to know what the impact was of certain decisions and certain actions. That's clinical utility, not clinical evidence. But for 3 years, the terminology was evidence. And to us in industry and to us across the system, that evidence is this is our product and this is what works.
So if we take it then, because I want to leave enough time for questions too, if we move to the future, and Sylvia, if we start with you, what do you think the future holds?
I think AI is taken off in an exponential way. I mean, it's just taken over. The other week, my daughter said to Siri, play gospel music, and it said, playing black gospel. So I didn't ask for black gospel, I asked for gospel music. And I think what we're seeing is that, for me, the future is training, making sure that we train the systems that are going to be used for diagnostics. We train it with inclusive data, the algorithms, the machine learning systems. We need to make sure that there is representation at the very beginning. I think far too often, I call it the lads in the lab mentality, where we're just focusing on the thing rather than the users of the thing. And it's not about debiasing people, because we all have bias and we can't get rid of it. If there is one person that doesn't have bias in this room, you should be on Oprah. Because, boy, you'd be the only person in the world without bias. It's about debiasing the system. These systems don't learn themselves, they are taught. So we have to really be intentional. It shouldn't be okay to have homogenous groups or non-diverse groups really making critical decisions that's going to impact a diverse. We should absolutely not accept it. And building enough time. I know about the time to market. We got to get to market. But at the end of the day, if we keep doing the same thing, we'll get the same results. And whatever we tolerate, we will never change. So for me, it's training the data, the system, the pathways to be non-biased. And also making sure that all clinicians, everyone is culturally competent, that I have a raised awareness of what my biases are and understand how to interact with different people. I always think that if we are not aware of our biases, we are asymptomatic. We could be actually enabling the very thing that we're trying to prevent. So for me, it's training the data, training the pathways, making sure there's that diversity of thought at the beginning, put the resources in, and then following it through to the end, along with cultural competence for the clinicians and the professionals who will actually be engaging with patients.
Yeah. David, what's the future for you, do you think?
Yeah, I'll give it, I can't compete with Sylvia's expertise. I'll do a different angle of things for me. And I think my main message is to you, I'm hoping that we have truly integrated systems, in the way that I was describing before. I think what we're likely to see is, if you look at Darcy, we haven't mentioned Darcy yet, the kind of things that were coming through last week, no big surprises in there. But if you look, going back, I was joking about it before, 44 years I've been around this. Our healthcare assistants and our practices, they do injections, they take bloods. That's perfectly normal practice now. We've gone from, in primary care, a GP-led system now. So GP started to become a bit like you have in secondary care, where you have a consultant managing a multidisciplinary team. I know it's a bit more complicated than that, but you get the same kind of picture. So one of the challenges for you guys, and it's a challenge I've applied when I was going around the exhibition stands, and it's something I've talked about before at these events. How do you keep the scientific precision and the evidence and the validity of things, but make something simple enough for people to use? That increasingly it's either going to be the patient or a care assistant or a healthcare assistant rather than somebody who's a very senior healthcare professional. And I think that's a real challenge. Whenever I looked at the stuff before, I'm thinking, well, how would I use that as a patient or a certain kind of patient? I don't want to name too many systems or I'll annoy people, but you might have seen something today which is replaces the dipstick urine. Do you think that? That was interesting. And again, I was going back, it's only 2 weeks ago I chaired an educational meeting of our healthcare assistants. It's really interesting to hear the things that they do and their roles. But I kept thinking, so how would they try to use it? Do they understand what it's for? Is it training? Is it education? So I think that's one of the challenges. We got to, whether it's AI or whatever it is now, we've got a much broader group of people getting involved, either as users, and users is in the wider sense. You know, I used the word meta-primary before. You know, and one of colleagues to right is on there, Helen or Lucy, was talking about that as one of the changes, that people are much more participatory now, whether it's through using Google or whatever it is. So when I look to the future, final things though, you mentioned about hubs. So we've got 61,000 patients. We cover more square miles than Greater London with 9 billion patients. So what we're looking at is, instead of every practice having facilities, of using hubs, which we would like to be sort of hub and spoke related to your hospital, laboratories, and your services. Something else I've aspired to, you might see this as heresy, is the kind of people you probably manage, or it might be some of you, physically working out in those facilities. Okay? Being sort of community-based scientific officers. So this, I personally think that is inevitable. And I'll leave you with an NHS acronym if you want to look it up. Because again, forgive me, I realise that most of you are familiar very much with secondary care NHS. How many people are familiar with an acronym called ARS? A-R-R-S. ARS? Yeah? Rob is? Catch Rob afterwards. He's happy to stay till 8 o'clock and explain. But if I was at a primary care audience, okay? So round about a fifth of all the staff involved in primary care now are funded through ARS, Additional Role Reimbursement Scheme. It's bringing in physios, pharmacists, advanced practitioners, GPs, dietitians. One of the roles it doesn't have are scientific officers like you. The way that it's been defined now allows us, I think, to start to change that. So the final thing I want to leave you with is the prospect of being community diagnostic officers and community hubs that would be linked to you as the leaders of it, as I was saying before, not in opposition, not in competition, but in an integrated way with you. I think that's not very far away at all, particularly in rural areas like us.
Let's finish, Helen, with you, a comment on innovation from the industry perspective and some hope for the future.
Okay, so I think in some cases, innovation can be too technical sometimes, and the TPPs or the requirements or the ideal situation or the clinical needs are exciting. It's what people think they want, and it's got a lot of potential. However, what we're finding, and I think this is some way to the adoption, is that the NHS, this is from Darcy, it's an analogue service in a digital age, and some of our kit can't be used. The system is not ready for it. There are anecdotal, because it is anecdotal, I haven't got the evidence for it, that point of care services are being done offline because the IT department won't allow them to be into the network. So, which is ridiculous, because, you know, we are designing, so we're a little bit too technical, so we need to work with you, and we need to have proper collaboration, proper engagement, and those are the proper conversations of, you know, sitting down, what do you actually need, identifying what that need is, in order to be able to develop that at a pace that the system can cope with, while still future-proofing it and having that technology, because patients are going to be at a position where it just can't get into the NHS because it is not technically advanced enough to take the product. So I would like to see that change, and that will come through engagement, and that will be, in its simplest terms, it will be making an appointment with the rep of the person who is making that product and discussing how and what is needed to be done from both perspectives in order to get that product used. That is the only answer to adopting innovation, is understand each of the barriers and the capabilities and the difficulties and address them together.
So let's see if we have any questions as we come to the end. Does anyone like to ask a question of the panel? Maybe?
I'll shout. Yes, so it's Wendy Johnson from BHR Biosynix. My question to the panel, I'm interested in something that's not really been touched upon at all, and that is the role of pharmacists and how they can actually be considered for the future needs of NHS diagnostics, because we have pharmacy first, and to your point, David, how can the community here engage with pharmacists to make sure that's rolled out?
Yes, we could probably have a whole panel, couldn't we, Josh?
Yeah. I'll be really quick, because I think it comes into Sylvia's thing as well, because it doesn't matter whether it's an area like mine, the little village I'm in has still got a Boots, but if you go to a city and an estate there, the thing about pharmacy first, I've been on groups, ICB groups, and people will say pharmacy first, and it just comes off their tongue without thinking, what's it actually like for the pharmacist and the pharmacy trying to make a living at the moment, and the nature of the way that people come in, and can you really say, no, I'm going to spend 45 minutes with you and sit down and do this? So it all comes back to the point I was saying about integration, and about us actually bringing a national health service into action. But I don't have any ready answers other than to totally agree with you. I'm really glad you asked the question. It's an example of that meta-primary that I was talking about, because it even leads me then to say, yeah, okay, the pharmacy, but what about the library? What about the sports centre? What about the corner shop that now in urban Britain in particular is fantastic, isn't it? Is in my lifetime, shops used to shut at 5 o'clock. Now they're open almost 24/7 in places like London. Fantastic. So what terminals can you put into them? Yeah. So, again, Neil and I are interested. We've got 7 practices, three of them have got electronic portals where you can come in and do various things. It's great. But they only are in the GP practice. So let alone pharmacy, why aren't they in schools? Why aren't they in, yeah? So I think that's the whole thing, as Lucy's saying, we could go off, but I'm really glad you asked the question, because you could have easily asked it about optometry. Yeah, we could have asked it about all kinds of different organisations out there. But because the patients, bless them, think it's one system, don't they? They don't realise how disjointed they are, or the fact that you've got things being used offline because the technology can't compete. Yeah, I think it's a great question. And for future events, Tony, I'd love to hear a pharmacist, a community pharmacist come, because I don't think people in the NHS generally, we don't understand enough about how pharmacy is constructed and how it's paid for and their activity and why certain things happen in pharmacy. Because it is a fantastic thing. And I mentioned Boots deliberately and not advocating them, but they got a strap line, isn't it? Something like it's a massive proportion of the population live within a very short period of Boots, let alone all the other independent pharmacies. So it really would be good. Is this a great question?
Yes, I was just going to say that's a really interesting question that you asked, because I live in Berkshire, and to be honest, the role of pharmacists just seemed to be disappearing, and I think it's in the wake of AI. I used to get prescriptions and repeat prescriptions and go in and speak to pharmacists. Now it's all done online. So I think it's what is the future of pharmacists and what can you offer that's different? There's definitely a gap in the community to fill, but I think pharmacists need to almost like reinvent themselves and get ahead of, if not on par with AI, because now it's like shopping on Amazon. I can just go onto my post office app and order all my repeat prescriptions and they come. I don't need to go to the pharmacy. So that's a question that I would love to explore. You know, what is the role of pharmacists now? Because they seem to be...
Yeah, just very quickly, we've recently had a pilot, you might have seen on the news, where we're getting medicines delivered by drone because of our rural area, you know, so it wasn't successful.
So we could talk for another 45 minutes, I'm pretty sure of that. And I'm going to bring the conversation and the panel debate to a close. But of course, we've got further networking on the agenda and obviously visiting through the expo, and we'll be here for the next few minutes to answer your questions. And just to first of all say thank you so much to our panel members for being here today and being available to talk about the topics of current and future needs for diagnostics. I jotted down as we were talking some of the key words that came up. So community, evidence, inclusive data, place-based testing. I really like the discussion about the patient or the people not knowing what to ask for and even to how to have a conversation with their healthcare professional. And that piece around mistrust, which makes me sad, but also positive for the future that we can change that. What does good look like? And those decision making, we started off by talking about 70% of decisions. I think that really goes to show that the information that's needed to go into clinical decisions is vital, and that's what we all take part in producing. And really making sure that we are training in diversity. I love that, Sylvia, from the beginning. So thank you for listening, everyone. Thank you again to our panel. If we can give our panel a round of applause.